The original pit procedure, the suture passes directly through the biceps twice. And so the problem with that, in my opinion, is that if the biceps tendon tissue is not robust, that suture can pull right through the biceps, just like the suture can pull through a rotator cuff that's on an open. With the modified suture technique, you can see here the suture goes behind the biceps. Okay, and so when you pull on that suture, it now is like a purse string. It actually grabs the entire width of the suture and is much, much stronger. It greatly decreases the chance that the suture pulls through the biceps tendon. And so here's an example where this is the key. You have to retrieve the relay behind the biceps on the second stitch. So on the second pass through the biceps, you retrieve the relay behind the biceps, posterior, and then when you load that suture, that gives you a loop that goes around the biceps. And after doing that, you cut the biceps tendon and retrieve the sutures in the subacromial space, and that will give you a nice, strong, soft tissue biceps tenodesis. I do this a lot. I see a lot of biceps pain, and I see a lot of degenerative slap lesions. I hesitate to call them slap lesions in somebody who's 60 years old who's not growing, but they cause pain. It causes pain. And so I treat it because I think this is a very simple way to treat. Not as simple as a tenotomy, but this extra 3 or 4 minutes prevents the cosmetic deformities. That's one less discussion we have to have in the office, so the patients are happier. This technique was developed by Dr. Schneider, and he calls it the rabbit procedure. The rabbit is a mnemonic that stands for using a suture anchor, particularly a Revo metal suture anchor. And the technique is very, very similar to the postural repair that we talked about yesterday. You clear off some of the cartilage from the humeral head anterior to the biceps tendon, and then you place a suture anchor into the humeral head, and in this example it's a double-loaded suture anchor. And then you take those sutures and you, again, use a spinal needle just to pass through the biceps. You bring your sutures through the biceps, and then you tie the sutures intra-articular. It's a very secure fixation because you have a suture anchor holding the biceps. I've done many of these. I used to do many of these, I should say. That soft tissue technique has now replaced this technique for me because I think it's just as strong. And I had quite a few patients that continue to have anterior pain because the suture that you leave in this technique is right in the bicipital interval, in the rotator interval. Okay? And so I would have patients that would have occasional clicking or would have pain after this procedure. And I never had that problem. I haven't really had that problem with the soft tissue tenodesis technique. So I present this as an option, and I've done more than a few, but in looking at the results, I think that patients have less postoperative complaints with the other technique, the soft tissue technique. And so now we move on to proximal tenodesis, or outside the joint. There are still many different options. You can tenodese in the subacromial space. You can tenodese with a suture anchor or an interference screw. And the main surgical advantage is that this is a very strong tenodesis. Some of the disadvantage is that if there's distal biceps pathology, just like the other intra-articular technique, this technique will not take care of significant biceps pathology in the bicipital groove. It is technically a bit more difficult than the soft tissue technique. It is a bit more expensive because now you have a suture anchor or an interference screw. Here's an example using an interference screw for a proximal technique. And this can be done in the subacromial space, or it can be done through a small axillary incision. Tenodesis, let me go back. One other comment about the proximal tenodesis. You don't have to use a separate fixation. If the patient also has a rotator cuff tear, you can incorporate the biceps tenodesis into the anterior portion of your rotator cuff tear. So it doesn't necessarily require an additional fixation, an additional suture anchor or interference screw. If the patient also has a rotator cuff tear, you can incorporate that into the rotator cuff tear. In my technique using a triple loaded suture anchor, we could use one of those sutures to tie through the biceps tendon also. So it doesn't automatically require extra fixation. Now this technique is a bit more distal. This is in the bicipital groove. And my preferred approach is to use a small axillary incision because it's a very cosmetic approach. The patient cannot see it after it heals. And it's a very, very easy surgical approach. It's between the, or underneath the pectoralis. There is really no significant neurovascular structure at risk. And once you make the skin incision, you can just use your finger to spread underneath the pectoralis and reach over to the bone. And as soon as you get a retractor on the humerus, you then are looking at the bicipital groove. And so it's a very quick approach, very, very technically easy surgical approach. Once you make the approach, you have to choose what implant you're going to use. You can use interference screws, which are okay. My preference is not to use interference screws, but that is one approach. This is a very interesting approach that is relatively new that I have not used personally, but I'm interested in it. This is using an endo button, the same endo button that we use for ACL reconstruction or other procedures. And using an endo button, you pass it through just one cortex of the proximal humerus, and the button is organized so that when you pull on the sutures, it pulls the biceps tendon down to the bone. And then you tie the sutures. And so it's a very strong technique. This was studied by Dr. Aurora and published this year in the Journal of Arthroscopic. And what he found was that it was biomechanically as strong as an interference screw. So those of you using interference screws may want to have a look at this research and see if you want to try this technique. What I prefer is to not use an implant at all. So I prefer to just make a hole in the bone, as shown on the right here, and to make actually 2 holes, or in this example, 3 holes. The proximal hole is big enough for the biceps tendon to go completely into the bone. The other 2 holes, so the 2 holes that are key and key, are smaller. They don't need to be big holes. In fact, you do not want those holes to be big because then you'll run the risk of fracture. So those holes are smaller and are just to pass the suture. Once you pass the suture back through these holes, and I use a relay, I just pass a relay through this hole, I retrieve the relay here, load the sutures into the relay, and then pull the relay back out. And that brings the sutures out through these 2 holes. And the more you pull, the more it pulls the biceps into the bone. Once you pull those sutures, and the other really important technical fact is you don't want to secure the biceps until you have the patient fully extended and pronated. Okay, because that puts the biceps at its longest distance. And so if you do the fixation in that position, then you know that no matter what the patient does, it will never be tighter than that. If you secure it like this, and then 3 days after surgery, the patient goes like that can stretch under repair. So it's very important when you actually are trying the sutures in this technique to tell your helper, straighten the elbow, pronate, and then we tie. And then after that, no matter what they do, it's always at less tension than the moment of fixation. So putting it all together, if potential cosmetic deformity and loss of strength or cramping are not significant concerns, sometimes we have patients in Dallas whose arms are so big that they would not know if they had a cosmetic deformity at all. So that is no longer an issue. So we cut the biceps and continue. If those are not concerns, tenotomy is still a very good operation. Obviously in Europe they do lots and lots of tenotomies with very good success. And I think it's still a good choice for the right patient. In my practice, I've really reserved tenotomies for my patients that are significantly older, very low demand, and the reason I do that is because the soft tissue tenodesis is so quick and so easy that I feel that unless there's a strong reason to just do the tenotomy, I do the soft tissue tenodesis. It's almost the same time. So if the patient is concerned about cosmetic deformity or possible loss of strength or cramping, then your choices are many. The arthroscopic soft tissue tenodesis, whether the modified PIT procedure or the transfer to the conjoint tendon, which I don't think any of us will do, or the arthroscopic anchor tenodesis with an interference screw or a suture anchor. And the extra note that if they have a rotator cuff tear, you can add this to your rotator cuff tear. Or an open tenodesis, whether you use a direct anterior approach or a subpectoral approach. My preference is the subpectoral approach because it's cosmetically a nice approach and a technically easy approach. Once you make the approach, you can decide to use a suture anchor, interference screw, endolet, or use no implant at all and just use the bone tunnels. So hopefully this gives you a little bit of a structure or a peek into my mind and how I structure my thoughts when I'm dealing with patients with these sorts of clinical problems.